Hello and welcome to the show. I'm Dr. Ronald Yap. Today we'll be discussing prostate cancer survivorship. Modern medical advances have allowed more people than ever before to live through their cancer rather than succumb to it. However, after life-saving therapy, patients enter a new phase of life where issues such as follow-up visits, maintenance treatments, and adjusting to the side effects of treatments and the complications of therapy come to the forefront. Dr. Joe Madden-Fuentes from Concord Hospital joins us to educate us on these issues. Here's a brief bio sketch of Joe. He originally hails from Costa Rica, received his undergraduate degree in biochemistry at Vanderbilt University, and then went to Baylor for medical school. Dr. Madden-Fuentes then stayed in the South with a urology residency at Duke University, and then he completed a fellowship in reconstructive urology and cancer survivorship also at Duke. He just joined our practice last month, and we're very excited to have him join our team. So welcome, Joe.
Thank you very much.
Thanks for making it.
I appreciate the invitation.
Yeah, who knows, we can I can get so much from Google and LinkedIn.
Go.
Isn't that amazing? Like the internet's so cool.
Of course, you can find anything, correct.
So you just joined, so we had a lot of, preliminary discussions because new freshly minted, fully trained, fellowship trained urologists, and guys like you have kind of the world is your oyster, particularly with your background. So what brought you to Concord? I'd like to warm up all the people that come on the show. What brought you here to the medical community and to the area?
Sure. I never really expected to be in the Northeast, but when I was looking for the right practice to begin my career, I wanted to have a pretty kind of diverse set of choices. We looked at, my wife and I looked at areas in the Northeast. We were very attracted to New Hampshire just from the natural sort of beauty of the state. When we came up here to interview, I fell in love with the tremendous group of urologists that are part of the Concord Hospital urology team. And then just looking around, I just loved the size of the town, the kind of great kind of life-work balance that this town really embraces. So those were some of the major drivers for being in this area. I also felt like the hospital really had a drive for making sure that the patients got the best care possible, and they appreciated and embraced subspecialty training, which I think is critical to deliver very good care for patients.
Sure, I kind of joke around that we're like country urologists here, but it's kind of like a tongue-in-cheek thing because we're a giant regional medical center with now 10th urologists, subspecialty centers, and probably one of the bigger practices in the nation, actually. So we're just glad to have you join us because you fit in that jigsaw puzzle, with your skill set really well. So, with cancer survivorship, just to move on to the topic at hand, that's a relatively new topic, as I said in the intro. And in prostate cancer, just to keep it focused for this episode, what exactly does that mean? And I think there's a lot of controversy about prostate cancer, mainly because of those side effects. People say, "Oh boy, you get treated, and then you're going to leak, and then you're not going to have your sexual health, and you won't be a man again." So, what are those issues that you could deal with?
I think you mentioned something very important, which is the thought of what is a cancer survivor to begin with. We can think of a cancer survivor as someone who's been treated for a particular malignancy, specifically in this case, prostate cancer. But survivorship really begins at the time of diagnosis because there are a lot of emotional, social changes that take place and a lot of factors that each patient has to really decide on how important X factor is versus Y factor in their treatment options. And the side effects that can result from certain treatments for prostate cancer can really affect sometimes the patient's quality of life, and that's really what drives a lot of some patients' motivation for choosing one treatment modality versus another.
And I think one decision to be made because of that fear of complications would be the active surveillance cohort. So a lot of people nowadays do active surveillance, and that does work for some because the pro is you don't get any side effects if you're watching it. The downside is that if you are not a candidate, you don't qualify, or number two, you could have disease progression. For the people that do get treated or elect to get treated or need to get treated, and there's a whole variety of ways you could get treated, after initial treatment, what are those considerations that you would be concerned about in the survivorship department?
Sure. So I think the type of treatment that somebody chooses really drives what sort of post-treatment things I would be looking for. There are side effects related to radiation, side effects related to surgery. Specifically, the things that I would be looking at are the patient's urinary status, that is, are they having urinary incontinence or not? Are they progressing in the recovery of urinary continence or worsening? Is urinary incontinence due to stress-related sort of maneuvers, meaning heavy lifting, coughing, straining type of leakage? Or is it something related to urgency, which can happen with certain modalities of treatment for prostate cancer that are essentially triggered by other things, such as running water, standing, a sudden urge to go urinate, and then having some leakage. Other factors that we think about in terms of a prostate cancer survivor is erectile dysfunction or erectile function issues. Some modalities tend to have a certain percentage of patients that are more likely to have a certain problem with erectile function, whereas a different modality will have a certain different side effect profile. But bottom line, many men that get treated for prostate cancer also have difficulty obtaining erections, and they require additional assistance to help with that.
Mm-hmm.
So the major factors would be urinary incontinence, and my job would be to figure out what is the major driver of that incontinence and what can I provide in order to help the patient regain their quality of life if they continue to have urinary incontinence. Mm-hmm. And from the sexual standpoint, we have a variety of modalities that we can employ in order to optimize or help recovery of erectile function.
I see. And I think it's good to be intentionally vague, mainly because there's so many treatment options. Mm-hmm. And I think we could probably spend multiple episodes talking about just brachytherapy or seeds, and another episode strictly about radiotherapy or beam radiation, then one about surgery and the different kinds of surgeries, open, robotic, and different functions. But I think you've nicely captured it that in general, although there are actually procedural concerns you would have or radiation specific concerns, you're mainly talking about urinary issues or leakage of urine in particular. Correct. And sexual problems. Correct. And the nice thing about our hospital, just to give a little plug for our resources, is that when men have that initial diagnosis and that concern about survivorship, we have ample resources here. We have social workers. We've got a Hope Cancer Library at Concord Hospital, which is a fully funded library for free to people to research things and read or spend some quiet time just learning about the diseases. And also the Man-to-Man Support Group, which is one of the most active groups in the state. Gets a lot of people to our hospital, and there is open invitation. So for people watching that don't have a relationship with our hospital, you're more than welcome to come. Call the hospital and come to the Man-to-Man Support Group, because we do come now and then to give lectures and Q&A, and many men before, during, and after share their experience. And you can't take too much stock into how one particular person did with a particular treatment, because they're all different. However, their experience and journey is very, very powerful, just having been at those meetings. So let's take, for instance, an index patient, because since there's so many permutations, we should probably pick like one kind of patient and kind of go with it. Correct. So let's say we have someone that had a prostatectomy, radical prostatectomy or removal, and unfortunately they, obviously not done here, which is a kind of joke, because if you talk to any prostatectomist, they would always say that they never have anybody incontinent and no one's ever impotent. It's a tongue-in-cheek thing. Correct. But for people that do have stress incontinence, unfortunately, they're through that recovery phase. You would expect some leakage. You're out now a year, and unfortunately, this gentleman's wearing 3 to 5 diapers a day and can't really be active. We live in a state where there's a lot of people that like doing cool things. Skiing, chopping wood, riding their motorcycle without a helmet through the state. So what do you do with that guy? Decent incontinence afterwards. Not happy.
Absolutely. I think the most important thing is assessing the patient's quality of life and how they feel about their incontinence is number one, because that's really what drives whether somebody would want to consider an alternate, some therapy to manage their incontinence. The options are going to be, for the most part, surgical. Stress-related incontinence after that type of procedure typically can respond to surgical intervention. And there are really 2 options for patients. One of them is a male urinary, a male sling, which is a synthetic mesh that is placed on the urethra to essentially reconfigure how the urethra lies and how well a man can withhold urine so that they don't leak. The second option would be an artificial urinary sphincter, which is a 3-piece component that is implanted in as a either an outpatient procedure or an overnight stay type of procedure in the operating room. And the patient is able to actually control when they allow the urine to evacuate from their bladder. And that's driven by whether the patient feels that their bladder is full, whether they need to just go and empty their bladder because they're planning to do something else, like go outside and go hiking or go to dinner. I know that many patients tend to be a little bit concerned about their urinary leakage, largely because it does limit their ability to, in some cases, to go out, enjoy dinner, not having to worry about the odor of urine is very important for some patients, or just not having the concern that what if I leak so much that I make a spot in my pants, and it can be a little bit embarrassing. So for patients who feel that some sort of therapy may help their quality of life, those are very good options. How we decide which option is better for a patient, it depends on a multitude of factors. Number one, have they undergone any radiation therapy? Because one therapy is better suited for patients who have had radiation therapy versus another. For instance, most people would consider that a male sling is not as responsive in terms of improvement in urinary continence when somebody has undergone radiation therapy. Mm-hmm. Also, the volume of urinary leakage. How much is a person leaking? Is somebody leaking 1 pad per day, 2 pads per day, or having continuous incontinence where they have no control or no ability to actually generate a void because everything that they evacuate goes into their diaper as a leaking event. And for patients with higher volume urinary leakage, we think that the artificial urinary sphincter is a better device for those patients. Mm-hmm. The artificial urinary sphincter has been around for many, many years, since the 1980s essentially. Has changed very little since its introduction. It's a 3-piece component, as I mentioned, where there's a control pump, and there's actually a little cuff that wraps around the urethra to create pressure, and that's what actually allows a person not to leak. Mm-hmm. So those are kind of the options that some of our patients have.
Got it. I think the fundamental thing is, get checked out, and I think most people, when they get a particular treatment, and like I said, today we'll just say, for instance, prostatectomy, just so we have a pretty, clean line as far as the options, is that most people are just happy to be cancer-free. So thank God they're cancer-free, not happy with the secondary side effects, but just get checked out. Come see us. There are options. You're not stuck with that leakage. And as Dr. Madden-Fuentes noted, is that there are a couple of nuances to discern. What's the bother? What's the volume of leakage? So let's say it's a higher volume leakage type person, and really wants the artificial urinary sphincter due to the volume, and really is quite bothered by it, and really wants to go take that next step. What do you tell those patients about the prep for it, what to expect afterwards, and any potential downsides of that procedure?
Absolutely. So the prep for it, for the most part, is my initial evaluation to ensure that somebody would be a good candidate for it, somebody that I would think would benefit from the procedure. Other than there's no leading up to the procedure prep. The day of surgery, the patient comes into the hospital. They get checked in. We essentially get you over to the operating room. And in the operating room, we essentially make a couple of incisions in the body in order to implant this device. The nuances with it is, some procedures, the way that it's implanted is very important. There are a couple of options on how it is implanted, and that can affect how well it works. And we normally make an incision below the scrotum, which is approximately 6 centimeters, or about 4 inches or so, and another one in the lower portion of the abdomen in order to deliver all of the pieces of the device. It's usually an operation that takes approximately about an hour and a half to perform. Patients, after the procedure wake up, they're going to have the device turned off, meaning that it's going to be deactivated when they wake up. So we allow that to take place, meaning the patient continues to leak urine for the recovery time. And the recovery time varies anywhere between 4 to 6 weeks prior to them finally having the device turned on, so that the patient can learn how to cycle the device properly in order to control the urinary leakage. There are some risks associated with the procedure. Of course, there's the inherent risk of any sort of surgical intervention that requires anesthesia. Obviously, we worry about things such as heart attacks, strokes, although those are very uncommon, we have to make sure that everybody understands that a procedure is a procedure that does have some risk. But specifically to the actual surgery, the major things that we are mostly concerned about are two. One is the risk of an infection of the device, and that in some series can be anywhere between 2% to 4%, and also something called erosion. It's a plastic device that wraps around the urethra, and that device can work itself into the urinary tract and become exposed to the urine. If that happens, then that's considered an erosion. Both an infection and an erosion require us to, unfortunately, remove the device to allow the patient to heal. That, again, it's also in the range of 2 to 4% in terms of events for that. That doesn't preclude the patient from having another procedure down the line after the whole healing process has taken place. And you'd be surprised, some of the patients that I've taken care of that have a complication for some reason, they ask, when can we have another device placed, because it's made such a dramatic improvement in their quality of life to be able to be dry or have less leakage than they had when they came in to see us.
Thanks for the great overview. And I think, we talk about the complications, but one thing worth saying is that, this is a mechanical device. And, there's a reservoir that's in your, inside your groin and your abdomen, and there's a pump that's spring activated, and fluid is cycling between the scrotal pump and then the cup that's around the urethra. And like any mechanical device, there's going to be wear and tear.
Absolutely.
And things can kind of unfortunately go awry like any mechanical device. And sometimes, like anything else, it may have just outdone its longevity, and for a variety of reasons, be it erosion or what have you, it's just another mechanical device, and they have to get swapped out now and then, right?
Correct. It's not very frequent, but certainly it does take place. I would say most devices, on average, most people would tell you that they last anywhere between 7 to 10 years. I've definitely taken care of patients that have had it for 20 years in the past. So
no kidding.
It's extremely variable by the patient. So there's no one thing that I can tell a patient that would predict a very good outcome, meaning lasting 20 years, versus something that may last its normal average lifespan.
And it sounds like, aside from that, you want a motivated patient, it sounds like.
Yeah.
They have to be able to be cognitively able to work the pump, have the manual dexterity,
Correct.
and be in it, just because it could go great, but there could be bumps along the road, and it sounds like they need to be really well informed about what they're doing. I imagine by the time they get to you, they're motivated enough to want to pursue some form of treatment.
Oh, absolutely. It makes such a difference in somebody's day-to-day, given that most of the patients that have urinary leakage have to deal with that on a daily, hour-by-hour, minute-by-minute basis, essentially.
So it's kind of funny, as we're talking, I think about all the people that I've counseled, and what's very interesting is that going into a particular treatment, I've kind of noticed that a lot of people worry, the men, about the sexual stuff first. But actually, after treatment, they complain the most about the urinary part of it. And a lot of it depends on the age and everything. But even people with perfect continence or control, I know a lot of people, be it radiation or surgery, that still wear a male guard. They wear a liner, even if they're perfectly continent, because even the fear of leakage is enough to have them wear something when they do, like say, chopping wood, gardening, twisting, stooping, excessive hiking. Even if they're good, sometimes they want some protection just in case. So that tells you how much that means to them.
Yeah, that security pad is critical for some patients.
Yeah,
absolutely.
and we all, a lot of people even term that, social continence.
Correct.
Meaning you don't really need it, but you want it just to be on the safe side for your own, peace of mind. So thanks for that overview.
Absolutely.
So let's move on to the, erectile. I mentioned erectile dysfunction. That's another, of the big two things that people talk about as far as what they're worried about. So, ED, very common for men, particularly if you're 50 plus. I think one thing that we should say is that even before you get treatment, half of guys 50 years or older have ED to start with, or the erections aren't as strong as you would like it to, and any type of treatment certainly can't make it any better. So let's go back to that index patient, and let's pick radiation, because we've been picking on surgery too much, and we're both urologists, so we're probably going to get pilloried when this gets out there on YouTube about how we're like picking on the surgeons. Okay, so let's go pick on a guy that had external beam radiotherapy, unfortunately, had some erectile function but needed to use a pill.
Correct.
Now nothing's happening.
Yeah.
And what do you tell this gentleman?
So this scenario is not uncommon. Having a gentleman who's been on some prior oral therapy, and the therapies out there are really about 3 to 4 different types: sildenafil, tadalafil, vardenafil. Those are just the generic names for brand names that are out there. Some patients respond quite well to those medications, but sometimes those effects aren't durable in the long term. So what are the options? There really are about 2 to 3 other options for patients. One of them is going to be a little pellet that can be inserted in the urethra, so the P tube. And that pellet delivers a medication that dissolves and then allows blood flow to come to the cylinders in the penis that actually give you a robust or rigid erection. There are variable outcomes with that medication. People have reported that it's anywhere between 40 to 60% effective. So for those patients that does not work on, then the other option can be also self-administered injections to the penis. Believe it or not, sometimes some patients need to inject themselves in the penis. Now, obviously, once a patient gets beyond that barrier of having to do something where they're sticking a needle in the shaft of the penis, their outcomes are actually very promising. So about 80 to 90% of patients respond very well to just injectables for an extended period of time. Mm-hmm. And there's some flexibility in the dosing. You can start at a lower dose and titrate it up, meaning increasing the dose in order to make the erection last a little bit longer, be a little bit more robust. But obviously, we always worry about one of the major side effects or concerning side effects that would be having an erection that lasts longer than 4 hours. Obviously, that would be something that would require the urologist to evaluate on an urgent basis or emergent basis to make sure that we counteract that. But for men that do not respond or who say, I really cannot inject myself, the last sort of resort that we have and it's actually a very good option, is a penile prosthetic. It's an implantable device that can be inserted into the penis, and the patient can actually control the fluid amount within the cylinders that are implanted in the penis in order to essentially regulate the rigidity and the erection that a patient has. It does not affect sensation of the penis, so their patients are able to still have a satisfactory erection that they can use, and they control when essentially the erection comes down. So they have a control pump in the scrotum similar to the artificial sphincter, where they can inflate or deflate those cylinders. Mm-hmm. And there are some very satisfied patients with that type of device. Those devices are very durable. They can last anywhere between 10 to 20 years. Some of the first devices are still out there in some patients, meaning that there's some very long-term durability to these devices, and patients like it, meaning they have control. They don't have to worry about taking a pill or injecting themselves, so it gives them a little bit more of ability to control the environment in which they're using their erection.
Mm-hmm. And it sounds like in these studies that the satisfaction rate is high, both with the patient and partner. And it sounds like in these studies you're talking about at least a 90%, correct me if I'm wrong, satisfaction rate if you pull patient and partner, which is the most mm-hmm. important thing. A lot of the studies don't necessarily talk about partners, yeah. But for the prosthetics or devices, for people that do decide it is a very effective option. Yeah. And what you talk about the implantation, very similar in process to the sphincter.
Correct.
Essentially, you're talking the 3-piece, correct?
Yes.
And there are other types. Can you briefly talk about the other types? Yeah. And I think the 3-piece is the quote-unquote Cadillac that most people decide on getting.
Absolutely.
But just give me a little brief walkthrough on what's going on there.
There are other options, one of them being malleable devices. These are devices that do not have a fluid fill component that then has to be inflated or deflated. These are devices that are inserted into the penis, and they literally have rigidity at all times, but somebody controls whether the device is in the erect position or in the flaccid position. That's why they're called malleable, meaning that you can kind of mold it to however you want to use it. The other option, there are some 2-piece components, meaning devices that have two essentially parts to it that still function in a similar fashion, where you still have to pump, and then the way that you activate it is just slightly different. Mm-hmm. But there are, and just like as a recap, 3-piece components, which are, as you mentioned, the Cadillac model of the device. You have 2-piece components that are appropriate for some patients, and then you have malleable devices for somebody that doesn't really want to deal with the pumping essentially of the device. Mm-hmm.
And since it's quite similar to the sphincter as far as another prosthetic type device, any differences in that walkthrough as far as the patient, as far as the aftercare or
Sure.
the process? Tell me about that. Walking briefly through somebody through that process of getting one.
I think it's very similar. You come to the operating room. We make an incision in right below the penis, right at the junction of the penis and the scrotum. And through that one incision, we're able to essentially insert all of the components of a penile prosthetic, whether it be the 2-piece, the 3-piece, or just the malleable device. Typically, the operation takes about an hour to an hour and a half. The patients stay in the hospital overnight. They do have a catheter for the overnight time. We keep the patients mostly to make sure that everything looks normal after surgery, that their urine is draining properly, and then the next morning we remove the catheter, and as long as pain is controlled, they go home. The device cannot be used for approximately 4 to 6 weeks. Most people say about 6 weeks before you can cycle the device, meaning pumping it, largely because there's going to be a bit of swelling and tenderness in the scrotum, and it's going to be very challenging for anybody to try to push that button or that pump when you have swelling. It's just going to be a little bit uncomfortable. That's why we allow things to settle down for about 4 to 6 weeks, and then patients very easily learn how to activate the device, cycle it up and down, and we make sure that they know how to do all of that once they return for follow-up.
Mm-hmm. Great. And I think it's good to note that since you're here and you have all this experience in your training, I think we haven't really talked much or haven't inflated, no pun intended, your experience, but you're from Duke, you have a high volume of these things, and as we're going to a more specialized model in urology, I mean, I'm a board certified urologist. Yes, I can put that in, but it's been a while since I've done it, and I think nowadays in medicine and in surgery in particular, we and patients want people to do a lot of a particular thing.
Correct.
And given your experience, you've had, sounds like ample volume in prosthetics as far as sphincters and penile prosthesis surgery. Not that there aren't other options. I think we could spend a whole show talking about ED as a whole without the prosthetics, but in light of the survivorship issues and your experience, thought it would be good to highlight those things. And it could be good food for thought for the next topic, because we can do a whole show on oral medications, vacuum pump, suppositories and injection treatment. So any last words as far as survivorship for the prostate cancer patient that you want to get out there before we wrap it up, Dr. Madden-Fuentes?
I think the most important thing to kind of think about is realizing what some of these side effects can be from a variety of therapies, and that there are options for patients, meaning that you don't have to go at it alone. There are people that have gone through the experience that you've experienced potentially, that have required therapies or procedures in order to improve their quality of life. And I think patients just shouldn't feel alone, meaning if there's a concern, it's something that's bothering you, you should tell your physician, and we're available to help you along the way.
Absolutely. Well, thank you so much for that overview. It's great to have you join the group. And
all right, thank you very much.